Welcome to Podcast UK.
Hello and welcome to Podplast UK. My name is Matt Stone. I'm a plastic surgery registrar from Yorkshire, and in today's Cappuccino break episode, we are talking about the delay phenomenon. So first of all, what is the delay phenomenon and why do we care? Put simply, the delay phenomenon, or ischemic preconditioning as it's sometimes also known, is a way of improving the vascularity of tissue to be used as a flap by temporarily making the tissue relatively ischemic. A controlled ischemic insult, if you like. This has a number of advantages, most notably in increasing flap survival, but also sometimes the size of a flap which can be safely transferred. Now this effect has been recognised for centuries, including in nasal reconstruction by Orantius and Tagliacozzi's work on upper arm flaps. However, it remains a useful technique to the present day. Similarly, ischemic preconditioning is useful in other areas of medicine. For instance, some studies have shown that ischemic preconditioning by placing a tourniquet on a limb and repeatedly inflating and deflating this to create cycles of reperfusion and ischemia may reduce myocardial injury in patients due to undergo cardiac surgery. But for plastic surgeons, it is of particular interest with regards to flaps. How this works in practice is by partially elevating a flap or dividing the peripheral blood supply. It is possible to trigger changes within the flap to increase its reliability. These changes occur over a window from 48 hours up until 2 weeks where a peak effect is seen, as different components of the delay response take effect. Interestingly, both arterial input and venous drainage can be shown to have improved. Several different hypotheses have been proposed over the years to explain the delay phenomenon. Firstly, there is an increased axiality of the blood supply to the flap, encouraged by the loss of the peripheral blood supply. There is hyperplasia and neovascularization of vessels within the flap. Furthermore, choke vessels to the peripheries permanently reorientate, contributing to the increased axiality. Secondly, the flap is exposed to relative ischemia at the first procedure, and this allows cells within the tissue to become more tolerant of relative hypoxia, resulting in reduced, or hopefully no necrosis at the definitive procedure. Thirdly, elevating the periphery of the flap divides sympathetic fibres, and as a result causes vasodilatation. It is also suggested that this results in dilatation of arteriovenous anastomoses, which increases non-nutritive blood flow by bypassing capillary beds. However, this means that at the second procedure where the flap is definitively raised, there are fewer sympathetic fibres divided, and less of a reduction in the nutritive blood supply. Fourthly, surgery results in a hyperadrenergic state, where vasoconstrictors such as adrenaline circulate in increased concentrations. Although this also will happen during an initial procedure to delay the flap, it is not sufficient to cause tissue necrosis of the flap. After the procedure, the concentrations of these vasoconstrictors return to normal. During the second definitive procedure, there is a further rise of these substances, but smaller than if the first procedure hadn't been performed. The flap, therefore, is more resilient to the impact of this hyperadrenergic state and less likely to experience necrosis. Finally, choke vessels permanently open anastomoses into neighbouring angiosomes to recruit additional tissue, allowing larger flaps to be raised than would normally be possible by incorporating part of the neighbouring angiosome. In 1981, Pearl proposed a unifying theory which integrated these hypotheses. A whole host of different signalling pathways are postulated to play a role, including vascular endothelial growth factors, interleukins 6, 8 and 10, lactate dehydrogenase, caspase 9, and tumour necrosis factor alpha, but there are still elements which we definitely don't understand. Now, of course, delay phenomenon can be done intentionally to improve or develop an axial blood supply where one didn't exist before, or can be an unintended consequence. For instance, there is evidence that patients who undergo DIEP flap reconstruction after previous cockers or phalangeal incisions for other surgical procedures have increased size of their deep inferior epigastric arteries and increased midline crossover due to the delay phenomenon, compared to those individuals who haven't had these procedures. Alternatively, if you are intentionally delaying a flap, you are raising part of the flap to render it partially ischemic, and there are different ways to achieve this depending on the tissue being transferred. Now, for a local flap, this could involve raising the flap on 3 sides without undermining, or elevating 2 edges and undermining the flap to create a bipedical flap. While, for a pedicled or future free flap with an identified blood supply, this may involve elevating the edges of a fasciocutaneous flap to remove any supply from adjacent skin. Conversely, for a muscle flap, this could involve dividing minor pedicles to make the flap less dependent upon these, essentially turning a type 2 flap into a type 1 flap with an augmented dominant pedicle by the time it is transferred, or turning a type 3 flap into a more reliable type 1 flap. So for example, if you want to make a superiorly based pedicled rectus abdominis flap more reliable, you can delay the flap by ligating the deep inferior epigastric perforators a couple of weeks before the definitive procedure. So the delay phenomenon is a relatively simple but powerful technique that can allow us to improve the axiality of blood supply, increase flap survival, and also increase the flap size that can safely be used, and an understanding of this technique is vital to any plastic surgeon. I hope that's been interesting. Goodbye. Podplast UK is a collaboration between UK and Irish plastic surgery trainees and consultants. The content reflects individuals' practice and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.